And I now request the last speaker of the JCM Shastri Symposium, Dr. Subramanian Swaminathan, Consultant, Infectious Disease Global Hospital, Chennai, to deliberate on infection renal transplant, tackling the menace.
Right. Morning, everybody. So I'm an infectious disease guy, so a bit of an odd duck in this group, I suppose. So I've been listening to a lot of things that's been happening. It's amazing how much technology we have today. But even in spite of it, the number one killer after any transplant is still infection in our country. So those are my disclaimers. A lot of infections can be actually projected for or predicted before transplant itself. We had a recent transplant symposium within the group of IHH, meaning Singapore, Malaysia, everybody included. And they were talking about highly sensitized donors and how they were giving things like rituximab and then basiliximab and eculizumab and alemtuzumab and stuff like that. My heart was just sinking. Do you know what we guys call alemtuzumab? Campath, do you know what we call it? We call it AIDS in a bottle. And you didn't even do anything naughty to get it. Right? It's that bad. It's actually worse than that. So we are creative in being able to push the envelope so much further. But that comes with a cost. So obviously a lot of this has to be budgeted for pre-transplant. For those of you who may not know this, today when you talk about severe and critical COVID, one of the most important risk factors is not whether they're vaccinated or unvaccinated, it's actually use of rituximab. Rituximab increases the risk of severe and critical COVID. I just look back at all my severe and critical COVID in 2022. 50% of it was related to rituximab use. Because it really kills your B cells and your vaccine immunity is gone for a long time. So, a lot of it has already been discussed, so I'm not going to go into the things which have already been discussed. So when we talk about guidelines, everybody looks at the guidelines and says, this is what we should do. But it's good to look at the backside of it and understand what's the data based on which we devise these guidelines. You know, we blindly follow a lot of guidelines. You know, if you have a positive IGRA or a positive PPD, give isoniazid. Does it hold true today? Does that even make sense? I think we need to ask some of these questions. I'm not going to go into this because a lot of it was already discussed. So obviously everything is about measurement and measurement and measurement. We need data. I think a lot of people have already said this. We need lots of data, especially from this part of the world. What is true in the Western world may not hold good for us. So let's be very honest about it. So how can we risk mitigate when it comes to infection? It is far more lucrative to prevent the infection than to treat the infection. I know it kills my business, but I prefer it that way. I prefer preventing an infection than to have to deal with the fallout of it. So obviously there is risk stratification methods that we do. We also examine the donor and the organ. Let's not forget the organ. And also lab screening of the donor and the recipient, of course. So donor risk assessment, some of it was discussed. Today we have patients who have all kinds of exotic histories. There are people who are doing amazing things, both in their professional life and also in their personal life. I have patients who go all over the world doing amazing things. So that makes it so much more of a challenge from an infection control point of view. Social and habits. Just so you know, things like drug abuse are no longer very difficult in our country. It's actually very easy to get inhaled and IV drugs. I have lots of patients who do things like that, just so you know. Obviously, cultures in serology. And this is another problem, cause of brain death. Very often we have organs being asked for and saying, okay, the patient is brain dead, can we take the organ? The question is, why is the patient brain dead? Like for example, if it's a central nervous system infection, the only infection where you're allowed to touch the organs is actually pneumococcal meningitis. Anything other than that, you should not be taking the organs. Why? Things like listeria are intracellular. It's known to be transmitted through transplant and therefore will kill your recipient. Unfortunately, these are not things that we routinely think about. So UNOS has devised this. I mean, how many of us have the luxury of looking at all of this in a cadaveric situation? Very, very difficult. So when we talk about testing again, it focuses on certain things. We talk about viral serologies. We talk, the bloodborne viruses, then the herpes family. But that's about it. We don't really test for anything else. People have died of transplant-related rabies. Can we test for rabies? The answer is it doesn't make sense. But what do we need there? We need good history. We need to find out everything about what happened to the patient. Yes, we can mitigate it. We obviously cannot make it zero, but we still can mitigate it. Now, as far as tuberculosis is concerned, in the donor, it's really not such a big a problem. We have actually taken patients, you worked up a patient, it's a cadaveric donor, and you've taken the organs and you've transplanted it. And then after transplant, you find out that the cadaver actually had, the donor actually had tuberculosis. What do? You can only say that I don't have any overt evidence of tuberculosis. There could still be covert evidence of tuberculosis. Please understand that it is a disseminated infection and it can be hiding in any of your organs. And that is why it is important for us to share information. If you have a kidney recipient who has developed tuberculosis immediately after transplant, it's important to notify the other centers, guys, careful, please watch, maybe your patients are also going to get tuberculosis. I had a couple of years ago, I had a patient whose liver transplant, post-transplant, he developed histoplasmosis. And I'm convinced it's donor derived. Immediately called up all the other guys and said, please, careful, you may need to put them on fluconazole at least. Bacteremic donors. I recently had a call about this. One of my colleagues called me and said, Subra, I'm having these patients where, you take the organ from a cadaver and the blood culture comes back positive. See, at the time of organ donation, if the person is in septic shock, there is a problem. But what about a person who's just going into sepsis? The problem is that many of the features of sepsis are not specific for it. These are road traffic accidents. They could have brain injury because of which the blood pressure can be going up and down. They could have tachycardia for no reason at all. So how do you know the person is septic or not? Let's say you take a blood culture and the blood culture comes back positive. You've already transplanted the patient by that time. How do we handle that? Kerala, this actually happened. Liver went to one unit, the two kidneys went to two different units. The liver unit, the ID guy saw the data from the donor and said, no, there is a problem. I think there is a risk of a donor sepsis and let's start antibiotics, which is more than what we usually do. The liver recipient survived, both the kidney recipients died of septic shock. The point is that bacteremic infections are not necessarily that evident. You can't look at the donor and say, a cadaveric donor and say, okay, this guy is bacteremic, or no, this guy is not bacteremic. Our current technology does not allow us to have such a quick turnaround where we can identify all of this. So yes, it does result in significant morbidity and mortality. And earlier what we used to do is routinely take blood cultures from the donor. Whenever our guys go out to get the organs, we take a blood culture from the donor, bring it back with us and incubate it if we think the donor was looking tricky. And my transplant team knows what I mean by tricky. So, okay, all of this has been discussed. Obviously, whenever we talk about all the guidelines, it only fixes half the picture. Not everything that you have in your clinical practice will be there in the guideline. How often have you looked at it? Okay, I have this problem. Let me see what the guideline says. You open the guideline and there's nothing there. So yeah, we have to come up with some educated guesses on what we need to do in our country. As far as the recipient is concerned, I love to see the recipient before the transplant because there are a lot of things which we can fix today before the transplant rather than allow them to carry that burden into the transplant. So obviously the history is the most important thing. My boss used to tell me 85% of medical diagnosis is made from history. Right, so when somebody tells me I'm going to send you a whole lot of lab reports, I send it back to them on WhatsApp, saying you keep it. I want the patient, I want to talk to him. Right, I need to ask him weird questions. I need to know, do you have a dog at home? Do you have birds at home? Right, all these things make a difference. Are you doing construction work at home? See, when we talk about fungal infections, it's inhaled and it's a big bugbear. You can't predict for all of this. So how do you ask for all of this? We also ask for things like, are you doing any structural work, construction work, yada, yada, all that is great. I had a lung transplant recipient who came to me and he said, I asked him what your hobbies are. He says, my hobby is collecting old legal documents. And old legal documents will have mold on it. I can't ask everybody if your hobby is collecting old legal documents, can I? Doesn't make any sense. But sometimes you have to start asking weird questions to try and identify the risk factors so that you can prevent a disaster later on. So obviously, focus on all previous infections also, because some of these things have a tendency of visiting the recipient later on to cause a lot of misery. Obviously, we look at a lot of the lab evaluation, and we also evaluate the vaccine status, and today we have so many more vaccines which are useful. Let me make this very clear. Every infection, it's not just about the infection, it is also about the immunological burden that it causes. In many, many situations, we have seen that an infection adversely affects prognosis. What do I mean by that? When we had HIV patients, when we matched them, people who had TB had a poorer 1-year survival as compared to people who did not have TB, even after the TB is fully treated. What does it tell you? There is something that TB does to you. What about community-acquired pneumonia? If you have a person who survives the community-acquired pneumonia, if you match them against controls in the population, they have a poorer 1-year survival. Every infection that the person gets adversely affects long-term outcomes, and this is something we don't really pay attention to. And obviously, we need to do everything to try and prevent as many of these as possible. So whether it's COVID, whether it's flu, whether it is pneumococcus, and hopefully shingles soon, I think we need to look at all of this and try and understand why we need to reduce the burden of it, not just for the cost of it in the immediate run, but also for long-term reasons. And letermovir has shown that preventing CMV actually has a mortality benefit. It's not just about treating it. Of course, that's in stem cell transplant, I agree. So when we talk to a patient, we ask them, what are all your current issues, including what is the diagnosis based on which you are having a transplant, relevant exposures, previous illnesses, medications. Oh, our patients take some exotic stuff. They only tell you what the allopathic medications are. They never tell you what Ayurveda, Suddha, Unani, homeopathy, all that stuff. Somehow that just doesn't seem like it. But those things tend to be important as well. Drug allergies and vaccination status. So I'm going to discuss some of these things in the form of cases. 43-year-old being evaluated for kidney transplant develops a cervical node. FNA shows granulomas, and FNA line probe assay done on this shows drug resistance. He's on INH, rifampicin, ethambutol, but he's resistant to INH and rifampicin. Here's the problem. In those days, we were seeing a lot of tuberculosis after transplant. But a lot of it was because our methods of diagnosing TB was so bad, we did not have amazing things like GeneXpert, MTB-RIF. So our diagnosis was so bad, a lot of patients were carrying TB into the transplant and being picked up after the transplant. Today, we are identifying these patients much before transplant, and we have the option to treat them. But also remember that TB is no longer what it used to be. About 10% of your patients with first-time TB are resistant at least to one drug. Drug-resistant TB, multi-drug resistance, which is INH and rifampicin resistance, is 3 to 5%. So in your patients with TB, either pre or post-transplant, for the love of God, please ask for AFB cultures. You cannot know what it is susceptible to without knowing that. And very often what happens is we tend to cut corners because we think, oh, this drug is nephrotoxic, this drug is hepatotoxic. That makes it even worse. So please ask for AFB cultures, know your susceptibility, because outcomes are going to be a major challenge if you don't do that. So 55-year-old with, so much so that I have stopped using isoniazid in my transplant recipients. The number of post-transplant TB that I have had in my liver and kidney and lung and heart, very, very small. Not enough to justify routine use of isoniazid in my transplant recipients. 55-year-old with renal transplant had chicken pox. She was seronegative, and then she comes back 7 days later. Somebody decides, okay, let's try and give her the chickenpox vaccine anyway. The point is that post-exposure prophylaxis with the chickenpox vaccine is useless because it's a very highly transmissible infection. If you're talking about very highly transmissible infections, the top two would be measles and chickenpox, and now we'll have to add COVID to that. So the problem is, if you are even in the same room as another person with chickenpox, especially in their infectious period, transmission is almost guaranteed if you're vulnerable to it. So in this patient, you have to delay the transplant, make sure that they get over the chickenpox and whatnot, because you really don't want to be transplanting somebody with active chickenpox. That would be a disaster. Or worse still, you do the transplant and 3 days later that person develops chickenpox. Oh, things like this have happened. Okay, these are not made up stories, by the way. These are all things which really happened. So 36-year-old from my Hyderabad center liver disease for a liver transplant. He had recurrent hepatic hydrothorax, so they kept draining it, and because it was getting to be more and more painful, they decided to do a pleurodesis with talc. I think people now prefer bleomycin and all that stuff, but again, talc is far more effective. But there's a problem with talc which people don't realize. So anyway, he had a pleurodesis 6 months before LDLT. 2 months after the liver transplant, he develops fever, lung infiltrates, and graft dysfunction. And you see nice nodules in the lung, turned out to be aspergillosis. How did the aspergillus get there? Talc is loaded with aspergillus, right? So I would have loved to know this before the transplant. If they had told me that they had given him talc for pleurodesis before the transplant, I would have been, yeah, but we don't get to choose all of these things. These things happen, but at least we can mitigate it by using appropriate responses. I'm not going to go into this. Post-transplant living is another area which I think we don't spend enough time on, to try and teach them how to mitigate risk. We tell them, wear a mask, eat safe food. Good advice, solid good advice, but is that alone enough? Now, obviously, post-transplant vaccination is gaining importance. Shingles vaccine is coming up. There are a lot of other vaccines which are coming up. Obviously, regular monitoring, clinical follow-up is key. You guys will be seeing your patients fairly regularly in the first few months after transplant, adjusting immunosuppression, and as the immunosuppression starts coming down, your risk also comes down. But what is also important is preventing exposures. You want to minimize the risk of the patient coming in touch with the pathogen. Because if the patient doesn't come in touch with the pathogen, it doesn't matter how immunosuppressed they are not going to get infection. And obviously, animal avoidance. I'm not a great fan of people handling animals immediately after transplant. Travel safety. Food and water, I'm not going to go too much into it. This is a real life story again. This is a patient who had a liver transplant 3 years prior to this, meaning he had a liver transplant in 2011 in a Hyderabad center. And 2014, he had come back. Exactly 3 years after the transplant, he had gone back to the Hyderabad center. And remember, in liver transplant, the immunosuppression is far more gentle than what you guys have to use. So he had no rejection. He was absolutely fine, doing very well. And then he presented with this nose where he had a small black lesion. You can see the top photograph. Actually, that was the first time he presented to us. But he had gone to his private doctor with a small lesion over there, which was even smaller. And when you go to a doctor and the doctor says there's an infection, what do you get? What do you get? You get antibiotics. Sir William Osler said, what sets man apart from other animals is his desire to take medicines. He was wrong. What sets man apart from other animals is his desire to take antibiotics. Right? Nobody goes to a pharmacy shop saying, I think my blood pressure is up, give me some blood pressure medicine, give me some diabetes medicine, give me some cancer medicine. No. They want to take antibiotics. Anyway, so he got amoxicillin clavulanate. And within a few days, the nose became really swollen, black, and bulbous. And I was on the horn, hollering at them, saying at the biopsy, this is looking very bad. I think I know what it is. So biopsy was done. By the time, you can see the bottom panel, how it looked. And what I did not show you is that his eye also had a red spot. It had already spread there. The diagnosis was fairly clear, zygomycosis. But the question is this. Why did he develop zygomycosis? So treatment was very simple. We did Shurpanaka treatment. Right? We didn't have to take out the eye, fortunately. Gave him treatment, antifungal. About 6 months later, plastic surgery, reconstruction of the nose, all that is fine. But why did he develop fungal infection? 3 years post-transplant, immunosuppression is minimal. It doesn't add up. So the question was, I told them specifically, he has done something naughty, asked them what he has done. Then when they talked to him and said, where did you go? He said, sir, 3 years over, doing very well. So I went back to my village and participated in a bullock cart race. The amount of dust and sand that's going, he actually went in a bullock cart. The amount of dust and sand that's going to come out is astronomical. So please understand, when the inoculum burden is very high, even without immunosuppression, you can develop infections. I'm almost done. So the point is that this is a needless event which could have been prevented if we had told him, careful. Unfortunately, we don't always do all of these things. I wish life were this easy, where we can say, if you find this, you do this. You know, that's a good thing, because if it was this easy, we will all be replaced by Chat GPT, right? I am confident that our skills, given that we have to multitask, will keep our job safe. Do not ask for things like this, because if we find things like this, we are dead in the water.